level 1 trauma center in the entire state of New York. And we have over 3,600 trauma activations yearly. Our adult ED is 70 beds. Our pediatric ED is 34. And our catchment area serves a population of about 3 million people in the 25 surrounding counties. And that's Eastern New York, Southwestern Vermont, and Western Massachusetts. And we're the only tertiary care center in the Capital District. The only thing we really transfer out, we have all the services and specialties and subspecialties. The only stuff we transfer out are our burn patients who need a burn center, and then people who need like reimplantation surgery. But everything else stays with us, and we take an extensive number of transfers from all over. So we see a lot of really sick and really interesting stuff kind of all of the time.
Wonderful. Well, thanks, guys. We'll kind of get down to brass tacks here. Hopefully Jeff joins us here again in a second. So we'll start out with hopefully kind of a softball question that I'm sure that many of you have answered plenty times over the years. But when considering applicants, what do you think are some of the unique benefits of APP applicants who did complete a postgraduate training program, potentially compared to APPs who didn't necessarily complete a postgraduate training program?
I can take that one to start. I think that they have, typically gained extensive experience over a short period of time. They have usually a strong procedural skill set and are obviously very motivated to learn and grow as providers. I think that I've noticed they seem to have an easier time assimilating into the emergency department setting than other new grads, because they've already spent an extensive amount of time working in emergency medicine beyond just a single or two rotations in school for just a couple of weeks.
I would have to agree with Sarah. There's a lot there that she said that makes a lot of sense. Other things that I see as someone that looks for post-grad training is it takes less timing to train them for the sites that we have in our area. If they've already been assimilated in the emergency department, it just makes sense. We don't have to spend as much time and effort into training these people to be able to autonomously see patients. Other things I think about is once you have that foundation there, you can kind of build on it. And so a lot of the organizations out there want some type of training program in place to make sure all PAs, nurse practitioners, whoever's working in the emergency department are at the same level. And so if you have a foundation already in place, it makes it that much easier. And plus, it always gives something to bond with them as we complain about how hard it was when we did post-grad,
I know we lost you for a second there, Jeff. So we were just talking about your perspective on some of the unique benefits that a postgraduate training program can offer a APP, especially early on in their career.
Yeah, I had a little technical difficulty, but what I can tell you is I started doing EM 33 years ago, and basically I was told, and I hope nobody's repeated this, and I'm repeating myself, but when I graduated from PA school, here's the chart rack, because it's that long ago. Here's the bathroom. You'll never get a chance to use it. The cafeteria, don't even worry about it. Go. And that's all the training we had. That was orientation. And I actually started in a 2-bed ER, which I had to walk up and down the hill, both ways in the winter barefoot. But really, I did start in a 2-bed ER, 10-bed hospital. And then within the first year, I moved to a 100-bed ER, 100,000 visits, level 1 peds, level 1 trauma, level 1 burn center. And that was still my orientation, was here it is, go for it. So the difference I see is, as somebody who's done it and somebody who hires people and now trains people, is it takes you 2 years to really get going in the ER. And that's with somebody really, I think, taking the extra time to do it. Because when I started at both sites, I was thrown in alone, well, not alone, but thrown in, and basically it was die or survive, and there was no in between. So, it was a sign of failure if you had to ask a question or if you needed help doing something. And so luckily this place I worked at was not quite that bad. So I survived. But the biggest difference is, the people come in, we have time to teach them. We have time to help them learn. We don't put the pressure on them to see 20 patients in 8 hours or whatever, your metric would be. So people come out, not suicidal. And I'm not joking about that. They want to learn. They're excited about learning, and we give them that opportunity. So it's night and day from when I started. And the best example I can give you is one of my partners who was my student, PA student, and then we hired him at that early way to do it. For the first month, he used to take every sticker home with the phone number on them and called every patient he saw the next morning to make sure they were still alive. So that's the big difference there from what we do now. So
very good. So I guess, when it comes down to brass tacks, for those of you that are currently completing a program or maybe have at some point, the big question is, what benefit is this going to offer me, when I kind of get into my real practice? So I guess 2 questions related to that is, in your guys' particular settings, do postgraduate trained APPs get any special or additional privileges compared to those APPs that didn't complete that training? And then also, are there any financial incentives associated with folks that have completed postgraduate training? Go in the same order again? Any order is fine. Paul, you're up first.
Fair enough. So with our organization, it depends on the region, the site, and those things. Every site or system has different roles when it comes to, if it's a rural site, hard to staff, then obviously there may be some financial incentives there. We are on kind of a tiered system in Central Texas where it will allow you to probably start off at a higher tier level than other, non-postgrad APPs, PAs, nurse practitioners. But as far as, for us at least, as far as making you more money, probably not so. Like, I won't make more than every other APP in the region, but it will give me a higher tier level and maybe start me off at a little bit advanced rate. That's about it.
And I would say things are very similar at our institution. So as far as privileges or scope goes, I would say that our postgraduate trained PAs have a shortened orientation period compared to people who are coming on that are not postgraduate trained or don't have prior experience. And most of them are credentialed for more like advanced procedures right off the bat. They don't have to spend as much time as long as they can like show procedure training records, getting credentialed for those procedures. As far as financial incentives, again, similar to Paul's institution, not very much. We have a tiered system, and I think the tiers are like 1 to 3, and then 4 to 6, and then I don't know what the ones are after that. But the year of postgraduate training does count towards your years to put you in whatever tier you belong in.
Jeff, are you getting rich in Michigan there?
Of course I am. No, and I can talk mostly about Michigan's setup a little different than the rest of Envision. There's little pockets of Envision that have their own things. I can talk about Michigan. So until just recently, all of our fellowship graduates have been from my program. So it's hard to say, but then we just hired one from Ann's program in Minnesota, and her husband's doing a fellowship in surgery. Anyhow, she came in as a sort of like an experienced PA would do. Our new hires, whether they're experienced or they're not experienced, usually have to go through about a year orientation with a little bit lower starting salary because we sort of overstaff them a little bit so they have time to learn the system, which you guys know every system's a little bit different. So a fellow that's a new graduate that we sort of have vouching for, and we know they've gone through a postgraduate residence, will start up higher than the new person, regardless of experience, because we know not only they have the experience and the training. You all have seen those experienced people that you basically have to completely retrain because they're trained wrong. So we have confidence in the SEMPA fellowship program that's been arranged. But the other advantage is our group in Michigan Envision has a partnership program. So not only that, there's a partnership program where you can be a associate partner, and then a senior partner, which those also add money on in our benefits package. So the advantage that we have at our company is that a PA and a physician in our partnership program will make the same amount of money, bonus money, as they do. Our salaries are obviously different, but in the bonus part, we felt we're contributing enough to the bottom line that they agreed with us, and they've kept it that way, and that's been very helpful. So those are the two ways: is you come in earlier and you can take a full credentialing package in with you, and then you can get involved in the partnership that much faster as well. So those are our sort of starting.
And then Leon posted a question here, so I think we have plenty of time to get to questions. If anybody viewing has any, just put them in the discussion. I'm watching that. So what are the main barriers to getting all new PAs going into emergency medicine postgraduate training, as opposed to the 9% that I kind of referenced in the intro there? So it's a great question. What do you guys think?
People, time, money. Money is the first one. It took me 10 years to figure out how to finance our fellowship, because unlike residents, many of you not know this, but physician residents get support from the federal government through Medicare, and we don't. So we had to, and we're not involved, we're not directly related. I'm at St. Joseph Ann Arbor, which does not have a university like the U of M to support us. They work with us, but we're not supported by them. So we had to do some interesting financing, which is a long discussion if anybody wants to talk to it, but we figured out a way to pay it off and still keep our program going. So the biggest thing is money, and there's no room. You got to have people that want to teach. If you don't, you're done.
I think the other side of that, at least from an Army perspective, when I was in the Army, the question was, why do I need a post-grad program when I can work in emergency medicine anyway? And so changing hearts and minds of the applicants is one struggle that we saw, at least from a recruiting side in the Army.
The only other thing that I would add to that is, I've always been emergency medicine, like even before I went to PA school. I never really considered doing anything else. But despite that, one of the draws to being a physician assistant for me was that you have that ability to work in any specialty that you want, and you can change your specialty without having to go through, like another full training program. I know we have physician residents right now. We had one a couple years back who had done pediatrics fellow residency, and then a pediatric ICU fellowship, and then decided she hated it and came back and did an emergency medicine residency. And I was like, I could not imagine, doing that. So I think that for people who, think that that's part of the draw to being a PA is, being able to work wherever you want, the extra training might not appeal to them.
We have another question from Ashley. So thank you, Ashley. What are your thoughts on fellowship PAs taking away procedures from residents, I suspect physician residents? I've heard about this being an issue. So it certainly is a hot topic button right now. All four of us sit on the SEMPA Postgraduate Education Committee. So we discuss these kind of things all the time. So we don't have the solution for this, but in your guys' particular institutions, especially if you have kind of various groups of learners, physicians and PAs and NPs and other various students, what have you guys seen? What kind of issues have you run into, and how have you potentially tried to rectify those?
I can say at our institution, when we initially started our fellowship program, it was not an issue whatsoever. And in fact, we'd have third years coming up to our fellows and being like, hey, do you want this procedure? And like handing them off over the we're busy enough that there's never been a real lack of procedures. I would say though that since COVID and having a lot of boarders in the department and that kind of stuff, we send a lot more patients to like VIR to have things like lumbar punctures done, or they do, chest tubes that are not emergent up in the ICU. So sometimes the procedures seem to be a bit less. And then I think with also all these, position statements that have come out from all these different organizations and stuff, I think as residents have kind of seen those position statements and gotten word or caught wind of them, I think it's kind of changed the view a little bit. Our solution is that we just kind of, have tried to keep the interactions and relationships with our resident fellows and our resident physicians and our PA fellows as collegial as possible, and kind of, reinforce that we're there to work as a member of the healthcare team, not take their jobs away, and everybody's kind of there to learn.
Play nice in the sandbox.
Yep, exactly.
Same rules you learned as a kid.
Yeah, we're lucky. Our solution is we have one main trauma center, level 1 trauma center that has residents, and then we have 4 other sites that we use within 20 minutes of our main hospital, where there's nobody but the PAs and occasional physicians who still like to do procedures. So we teach them the procedures at the smaller sites. They still get plenty of procedures at the big sites because, of course, the residents, there's only so many of them. And when you have close to 100,000 visits and 60 beds, we have plenty to do. We cover the residents on Wednesday, and we make sure that all of our fellows are there most of the time to cover the residents so they get the experience there. So our compromise has been having the extra sites to rotate through.
I don't think there's much to add than what Sara and Jeff has said. That's exactly what we try to do is we integrate our fellows with the physician residents, make them part of a team, but we also farm them out to some rural areas or rural sites that are level 2 trauma centers outside of our big hub in Austin. And there's enough procedures to go around. As long as there's enough meat, there's always enough to eat.
Yeah, I think you officially get old in emergency medicine where like you have a patient that needs a procedure, and if you're just working by yourself, like you get kind of disappointed because you think about all the phone calls you're going to have to make and all the paperwork that comes with it. So I'm there. I'm glad that I did the I did the residency program at the University of Iowa here, and it was certainly cool to do the procedures. But once you kind of get that excitement out of your system, then you get a little bit less excited about it, and that's when you get officially old.
I would say the other thing that I tend to do also, since I work night shift, and it's usually me, a resident attending in the area where I work. If there's not one of my fellows that are on working and there's procedures, I give my procedures to the residents if it's not something I really want to be doing. That way they kind of just know we're kind of out there to be on the same team and to watch out for my fellows.
Perfect. Let's switch gears here a little bit. So I think you guys can offer some insight in this. So at your guys' sites and practices, are there any non-clinical opportunities for EPPs in your practice setting, things like education, leadership, service, research, those kind of things?
I'll start this one. We're lucky. Part of our partnership that I kind of mentioned vaguely a little bit earlier is exactly that. We have struggled like every other institution in the country with burnout. So we've discovered that we ask the leadership in our team of the 5 hospitals, we'll ask every year, we have a 360 evaluation, and we say, what do you want to do? If you want to do leadership, we have a leadership development program, both at our site and nationally. If you want to do research, the IRB directors in the emergency department, we have residents who will work with them if they want to, and sometimes some of the residency services will too. As far as education, we have 5 PA programs within about 20 minutes from my hospital. So they're dying for people to teach. So what I try to do is get my people who've got some comfort. I actually get them starting teaching in the fellowship when we do lectures, and then I farm them out to the PA schools. Then they get experience with teaching. We go to the universities around us to teach ultrasound. I do lectures all the time. I even go to the undergraduates and do some of their pre-PA lab, where I'll take a bunch of chicken legs, turkey legs, and even there's about 6 of us that do med-mal cases, so we sort of encourage people to get involved in that to sort of protect our people. So that's one of the things our company is good about, and not just to put the company, but my philosophy too, is to get people involved in things that they can do and to kind of take up some time we get protected time for. And we encourage everybody to be on a committee too. So that gives you a few hours, and that's a committee, not just an APP committee, but a hospital committee. We want a PA on the pharmacy committee. We want a PA on the such and such committee. So we really try to encourage that, for one reason, to stop.
At our institution, we do have PAs and nurse practitioners involved in all sorts of, different non-clinical areas. One of my fellows who graduated from our fellowship program a few years ago, while she does still work part-time at an emergency department locally, she is the clinical site coordinator for the physician assistant program that's at Albany Medical Center. We have a research department within the emergency department. There is opportunities anytime anybody's looking to do research or publish to get involved in that kind of stuff. We precept the physician assistant students. We do occasionally precept med students. We do the splinting and suturing labs for all of the medical students. So we really do have quite a few different opportunities. There's also a group of us that are on the Diversity, Equity, Inclusion Committee, and we've started a program called the Dream Team, where we kind of go out into different high schools and stuff in the community, try and get kids interested in medicine and all different areas of healthcare.
To piggyback on what Sarah and Jeff said, I think we're all very similar in nature, where we do have leadership opportunities, educational opportunities. One thing that I found unique with the organization in Austin is if we also want to switch service lines, they will also send to train us to do other service lines, whether that be critical care, observation, those types of things, hospital medicine. So that way you can still bring value. You still get a different service line out of it. They say the grass is green on the grass is not always greener on the other side. In some instances, when you decide that you think you want to go into more hospital-based care, you realize that that's true, that the emergency medicine field is much better than anything else out there. So we like to prove that.
Hear, hear. All right, maybe one more kind of easy question, and then we'll call it good here. So for those folks that are kind of getting their CVs together, I'm assuming you guys probably get to read a number of those from applicants. What's one way to make your postgraduate training stand out when you're filling out that type of paperwork, CVs and things like that? Or just by having it on the paper, is that something that's automatically going to make you stand out?
So what normally I have been recommended by multiple people that mentored me coming out of postgrad is trying to craft your CV into what job you're looking for. So if you're looking for education, you may want to focus on how much you've provided mentorship or precepting, through your postgrad or after postgrad. If you're looking for leadership, then definitely kind of highlight that in the beginning with your postgrad experience, so that way you're focused more on the leadership side than anything. So for me, it's really gauging how to craft that CV to your audience, what job you're applying for.
And I would say we always, stress to our fellows, they do get to do, a significant number of procedures. And they do get extensive ultrasound training during our fellowship program as well, to, either have in their CV or a separate document where they log or can show they've done X number of this procedure. They've been signed off, credentialed to do these types of ultrasounds, or have done, this many ultrasounds during their fellowship training.
Jeff, any final thoughts in the last 30 seconds here?
Yeah, I'll make it short, but yeah, I think that just being a fellow graduate, most of the programs, the people you're going to look at hopefully will know the programs and the reputation. So I think that having that is just a huge bonus.
Well, that brings us to the end of our time here, but thanks to everyone who joined our little discussion here, and hopefully it was at least a little bit helpful. We always enjoy talking about these topics. So with that, I hope you guys enjoy the rest of the virtual career fair here, and be sure to check out all of the folks that are looking to hire all of you wonderful emergency medicine APPs. You guys are all making a great choice by doing any additional training, postgraduate training. I think it's gonna, pay off in dividends, and you'll probably appreciate that kind of down the road. But keep doing what you're doing. It's gonna, like I said, you're gonna have a great career. Have a wonderful evening. Thank you. All right, I stopped the broadcast. I think it's